Hello and welcome again to the Corridor of Hope podcast, in which we have discussions in regards to people experiencing homelessness and the troubles that they face, and what we do here at Bromley Homeless Charity with our partners and colleagues as well to try and help these people. So today we are joined by Mazen Nazzal. We call him Maz. He is from the Rough Sleepers RAMHP team with Oxleas, and of course, as usual, we are joined by Kim Sutton, who's the service lead manager for Bromley Homeless Charity. So Maz, if I can get you to introduce yourself.
Yeah, hi Sarah, good afternoon. My name is Maz and I am the lead practitioner with the Rough Sleeper and Mental Health Program at Oxleas NHS Trust, as you rightly said, short for RAM. And we cover Greenwich, Bexley and Bromley.
And you go out and do you just see rough sleepers on the streets in terms of their mental health, or what is the structure for the RAMHP team?
Well, yeah, so the team actually started coming to existence in June 2023, and this was the initial project, 2-year funded project by the GLA, the Greater London Authority. And the idea behind the service was that research suggests that a lot of people, majority of the people, or greater majority of people who are rough sleeping present with mental health difficulties. And the Maz's view and vision was that, mental health should not be a barrier to people returning to accommodation or preventing people from seeking help and support, and so this is how we started. But obviously, as we well know, it is not one thing or the other. A lot of our service users present with comorbidities, with physical health, or mental health, drug and alcohol, and so on. So we tend to, and we strive to take that holistic approach in terms of meeting the need as within our team as much as we possibly can. But obviously, it helps a great deal that we have a service like yours in Bromley here, Sarah, whereby you provide the physical health support. And I remember very well, I think this is about a year ago when we needed, one of our service users at the time needed some repeat prescription. The GP service was closed, and I contacted you, and immediately you stepped in and provided that. I mean, that actually alleviated a lot of anxiety, in terms of this particular service user. I don't know if you remember, I told you I was about to enter my car and drive down to see how I can support, but you saved me the trip, so thank you. And so this is a model of what we are aiming to achieve, really. It is not one service only that provides that support. It's about that collective approach, really.
So a lot of people have mental health issues, and I think over the years, especially around men's mental health, there's a lot more in the media now in terms of suicidal ideations and mental health is actually more spoken about now than it was previously. But I don't actually think people might understand the impact that rough sleeping has on people's mental health. So what have you seen in your day-to-day job? What is the impact of rough sleeping on mental health?
That is a brilliant question, actually, in the sense that, and this is what maybe we need to be aware of as services, generally speaking, when we look at adverse life experiences, and if you look at the stress vulnerability model, so whereby, people come to a stage where, you'll be going about your day-to-day life experiences and what have you, and out of nowhere, you have bad news. How do we feel? We feel down, maybe we feel depressed, and so on and so forth. Now, think about people who at one point or the other were in accommodation and then ended up being on the street. And what does that bring in terms of anxiety, in terms of the impact on mental health, the low mood, and the anxiety and the fear, not only in terms of being on the street in and by itself is bad enough, but also, unfortunately, how do society look at people on the streets also? What is the approach, And so that's the element of where I am in terms of my mental state being on the street, and how the society is looking at me, which will add on to that, right? And then with all the interlinked stresses that brings about. And stress is a very, very important factor in mental health, and often, as we go back to the stress vulnerability model, for example, often that is what the trigger for mental health breakdown. So it's very, very important. And we often see it in terms of anxiety and in terms of low mood and depression. And that translates to that sense of hopelessness and helplessness in people, And what is key for us, and this is something you asked me about the previous question in terms of what do we do, And through working with our service users, what is very, very important, I think, for ourselves, for all services, is that preventative approach, that early approach, provide that early intervention so that rough sleeping does not become prolonged, and so that people can return to leading a normal life as much as possible, supporting that recovery. And because the risk that is that the more and the longer people stay on the street, that rupture in therapeutic relationship, that mistrust in services and so on, become entrenched, and therefore it becomes very difficult, really, to build that support and that rapport again.
I think from a service perspective, we have to look at causation. So you'll pick someone up that's there. We look at the causation. How did that happen? And normally they're there because of a trauma. So they're already in a state of crisis at that moment, because it could be relationship breakdown, family breakdown, drug addiction. They're already in a trauma situation. So when Mazen and his team turn up, it's doubly bad, and then they're on the street. But the causation is the most important part for us as a service. We have to look at the causation. How did this happen before we place someone somewhere else? Because what you don't want to do is place someone in a situation they were in previously. So many people that we see that come in here have left their accommodation because the accommodation was full of other addicts. That is not good for them. Someone who's in recovery, back in an HMO full of other addicts, there's only one thing that's going to happen there. So we look at the causation of stuff. Maz's team is such an excellent team, so specialised in what they do. But obviously it's very difficult to give someone care on the street.
Absolutely, and that I couldn't agree more. And this is why what we're trying to advocate also, and part of the role we do is try to advocate with services and so on, is that, as Kim has rightly said, you can't provide that assessment and that care on the street, really. So what we do is that we're trying to advocate to services is that could we have, for example, a hostel whereby when people are off sleeping are placed in hostel whilst their applications has been reviewed for housing, that safe and private place for assessment, for at least they have a roof over their head, and again reduce that environmental risks, in terms of, like I was spoke about, the anxiety to themselves from others and so on and so forth. Because most of the time, because we spoke about media earlier on, unfortunately you only hear in the media about mental health in terms of when somebody with mental health difficulties or conditions negatively, has done something, but we don't hear about what people with mental health conditions or even rough sleeping populations experience. Yeah. And there was, as I'm sure you know, the study carried out recently by the Museum of Homelessness. One of the top causes of death actually is murder of the people who are sleeping on the streets. So it is a challenge not only for statutory services or voluntary services, it's for us as society as a whole, really.
For us as a service, and I just checked our stats, 70% of the people we see have a diagnosable mental health condition. It may not be diagnosed, but it's definitely there. Yeah. And that's 70%. I don't think any cohort of people in this country would you find that.
I've been working here 3 years now, and I think I've had one person in that whole 3 years that said, I feel fine. Is that anyone who's suffering or experiencing homelessness will have some degree of depression and anxiety just because of that situation they're in. Yeah. And then even when they're housed, I can imagine actually that they've then got the trauma of the experience of homelessness. So then actually that mental health concern, which might have started little, could actually turn into something bigger down the line.
I'll tell you a little story about the guy that we housed. We went round to see him just to do a welfare check, and his bed was on the floor, not on the bed. And I said, why are you down there? Because I'm frightened you're going to take this away.
Yeah.
And he's still living. This was 6 months later with that trauma, that this will be taken away. He's fine now. But when we walked in there and saw why aren't you sleeping there? Well, I'm not going to get used to it because it may be taken away. And they live with that constantly because it was taken away. Yeah. And I, in all my experiences of all the stuff I've done, I don't think there's anything worse than seeing someone who's been made homeless through no intention of their own, regardless of what that is, sitting on the street, not knowing what tomorrow's going to bring. Mm-hmm. And if you can't give hope to someone like that or reach out to someone like that, then like Maz rightly pointed out, we as a society need to look at what's going on, because you shouldn't walk past someone like that. You should always stop, in my opinion, and ask the question, are you okay? I mean, not everyone wants to do that, but, you know, as I've said to you before, I've seen animals taken off the street just like that. The RSPC go, that animal's being mistreated, let's take them in. But you'll walk over a human being and take the animal. I don't understand that.
Kim, I think you touched earlier on trauma, and I think that is, and this example you've given actually is again another good example in terms of how trauma affect people's lives and so on, and often the service or the people we work with and we find on the streets would have experienced, you know, horrific traumatic childhood trauma, adverse childhood experiences and so on. And I can't remember any case that we've worked with that does not come with at least 99%, I would say, you know, would have experienced post-traumatic experiences, really. And that's a challenge. And you spoke about in terms of accommodation, suitability of accommodation, you know. So, and not only in terms of trauma, but also neurodivergence, you know. And so when you have people who have ADHD and autistic and so on, so we need to, when we're placing people or considering accommodation, we need to look at not here's an accommodation, take it or leave it, or we need to make sure that it is suitable for people's needs, actually. It's not about ticking a box. You remember when we did the Southeast London, I think it was a good practice forum, wasn't it? And I read that part of that poem by Amira Saleh, I think her name is, from the Museum of Homelessness. And she spoke about when you are ticking boxes, you know, and empathy being a powerful tool, and for people who are sitting behind the desk and making those decisions, you know, these are very, very important and vital decisions we make in people's lives. And we need to be very careful and conscious of that. So placement, where we place people, is very important in terms of accommodation and making sure that it suits needs. Because again, if you look at data, about 25% of people who end up being offered accommodation from the street, off the street, end up to returning to rough sleeping, you know. And one of the things we're looking at in RAMHP is that why is that? But that's reflected in our own data, you see. But so we're looking at, you know, as why is this happening, you know? But what you often find is that the accommodation is not suitable for needs. And I can give you a lot of examples in terms of autistic person who was placed in HMO, you know, and the person did say to us at the time, and we tried to advocate, but nevertheless, you know, was placed, and within 2 months was back on the street, you know. So the other big challenge for us is that placing people out of their local authorities areas, you know. We had a person who was placed well away from the local authority, and when we followed up with them to find out how they are coping, they were resorting to using alcohol to cope with their anxiety. And that's something we spoke, maybe we've not covered in terms of people are on the street present with alcohol and drug use and so on. But again, why is that? Why are they using alcohol? You know, there could be a variety of factors, you know, to cope with anxieties, and maybe to cope with mental health difficulties as either to be undiagnosed and so on. Or maybe it's a form of self-harm because of a traumatic history that they've experienced. You know? And I think we cannot approach this group of people, particularly, you know, with any judgment. You know, we need to keep an open mind, and we need to have that professional curiosity in saying, what is happening in your life? Come back to your life journey, try to understand the person that's sitting before us and treat them as equal to us, with equal needs and so on, and be genuine about it. And
that's the issue. The issue I have, and I've done a paper for the government, I can send it to you if you want it, about why housing officers need to be trained. Because we are all trained in our professions, but the decision goes to someone that's untrained. That's difficult for all of us to cope with, because they're looking at all our evidence, they're making a decision, a life decision for someone, and this is a person that's untrained, doesn't do what we do. So I do believe that when you've got rough sleepers and those that are continually homeless, there needs to be a separate person that deals with that, someone who's either trained as a professional mental health, social worker, nurse, whatever. When you see the decision making and you go, how have you come to that decision for that individual?
Yeah. I mean, I'm a general adult nursing background, and I've had to put myself on multiple mental health, you know, study sessions personality disorders, you know, schizophrenia issues, and just general anxiety and depression, just to give me that little bit more, so that when someone does come in, if one thing is mentioned, it might trigger me to think, actually, I need to talk to Maz, because that could be more serious than actually what's coming on and things. And in terms of this podcast, when Maz, you were mentioning about unsuitable housing, it's not the fact that we're saying people should be housed in like single bed houses, like a full house or anything like that. It's lack of supported housing and things like that. And as you say, moving out of borough, we've had a few that their mental health has declined so much they've gone into full crisis and then been sectioned, because actually the charity here has become their support network for months whilst they're trying to help them. The same with you guys. I know you've become a support for so many people living on the streets that then they're moved to a different borough, and you say, and then they feel lost, and then actually some of them do become agoraphobic and just don't leave the house anymore, and that's not a life really. So it's just to confirm, in terms of housing, it is more sort of like around the support and things like that, and these will still be HMOs, like house of multiple occupancies, and rooms and things that we're still trying to place people in.
The system itself there is broken. And unfortunately, the lack of investment in housing generally hasn't been an issue for this country. And I think we have to look at that quite clearly, that there is an issue here. So people are being moved. If they've got a duty to them, they've got to put them somewhere. Yeah. I'm not saying it's anyone's fault, but please listen to the professionals that are saying to you, this will not work, this person will fail at this, because then 2 months later, they're banging on our door again. Yeah. We've had them turn up with their hospital gowns on here, saying, I can't cope anymore. And then you ring the hospital, go, you're missing a patient, because they're actually stood here with us. That kind of care of someone, you have to understand rough sleepers. And it's taken me 25 years of this job, and even I don't understand it sometimes, but I understand the care that has to go into it. These are people that are truly need complete all-round support. They need your care and attention. There isn't that many of them. Let's make that clear. It's not going to be a vast, great amount of money. We've got some of it under control here. So really look at the services, support services is where it should be at. The model needs to be, if we get this person off the street, how long do they need the support for? It should be as long as they need it for. And it's not just a GP support, this specialised support. And like I say, most people that are on the street and rough sleeping, there's some kind of trauma that they've had, that's why they're there. That needs to be addressed as well. But if you haven't got hubs like ours dotted everywhere, where do they go? They're relying on Maz's team, and Maz can't get out to everyone.
But that's a very good point, Kim. And what we're trying to do in try to address some of the difficulties you've actually highlighted now is that actually I've been in conversation with Louis. I don't know if you know Louis. And he's kindly actually recently approved the funding for a therapist in our team. And it's going to be for 1 year. And also generously, he did kindly again approve another funding for occupational therapist in the team. And the whole idea is that when I was talking earlier about understanding why people are returning to sleep and so on, to rough sleeping and so on, is to address all these challenges in terms of the trauma you've spoken about, in terms of suitability, assessing suitability for housing and so on. And I'm hoping with having a therapist in the team, a psychologist, would work with people, and try to at least try to unpick some of these traumatic experiences that
That's a great addition.
Yeah, absolutely. And with the OT, again, in terms of activities of daily livings, and so the approach will be for that strength-based approach. What skills do they have? How could we build on these skills? And hopefully then that the outcome we're expecting, hopefully that would reflect in a lower rate of people returning to rough sleeping, and as you had to say again, with conversations with local authorities, hopefully to take this feedback from ourselves in terms of abilities, in terms of trauma, in terms of report from the OT, and that will result in appropriate housing. So this is what we're trying to do, but we're taking it further also, what we've been trying to do and thinking about, because in my view is that the best way to approach and address rough sleeping is to prevent rough sleeping in the first instance. Again, you touch on a very important point, Kim, in terms of local authorities and housing officers, one making a decision to evict people, Is it because they have mental, which is what the mayor's office said in the first instance, is it because they have mental health and that's why they've stopped paying their bills, they stop paying their rent and so on. So we need to ask the whys. And what I've I've been approaching our colleagues in local authorities housing services is that if you have anybody who is at risk of being evicted and they're not engaging or open to mental health services, please reach out to us before you evict them, and we'll go over and make that one-off assessment. And if we believe that there is a need for mental health intervention, we'll contact our colleagues in Oxleas to provide that support. If we believe there is a crisis intervention, we'll refer to the crisis services also. But please, please do not evict until we've gone out to do that assessment.
And I think I've seen it from the stories that I've heard from Kim's team. They're not picking up on people not paying their rent and doing things months in advance.
Surefire sign something's wrong.
Exactly,
Yeah.
and then they're leaving it until the very last point, and then they just evict. When actually, if we caught them earlier, then that would prevent quite a lot of homelessness.
It's about linking things up. If you've got a housing officer and they go to their manager and go, Mr. Jones is behind with his rent for 3 months, the garden's not looking good, they're sitting there going, right, tick, 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 we'll have to serve them notice. Instead of going around knocking on the door and doing a welfare check.
Yes.
What's wrong? They could have lost their job, could have been a death in the fact, could be anything.
Absolutely.
But don't assume that person doesn't want to do something. It's intentional, because most of the time it is not intentional.
Exactly.
But they're not picking up on that, and they'll tell you. So the big housing associations tell me, we haven't got the staff to do that. Well, I would redirect some funds to do that, because the cost effect to the country is huge, because the knock-on effect on other services is massive. So you need to look at how your model is working. If it's not working, find another way.
Yeah. And since we've adopted this approach in terms of prevention, really, there's been a couple of cases in task and target meeting where, the local authorities say, we have this gentleman, we're going to evict him or evict her because they're not engaging with services, this and that. And when we've been, and actually it was very clear. One case had been having delusional beliefs and ideation for 20 years, but it'd been very low level, and actually that resulted in them leaving their job. And the belief was that the microwave and all the mobile phones, electronics, they're interfering with their lives and so on. And so we were able to provide that support. So these are things we are looking into. In terms of. But I also have to say, in terms of looking at services and how we can work together, in terms of the feedback we offer. Again, I want to give credit to you, Sarah. If you remember when we first started RAM, initially we were only getting referrals from people who are verified and from Thames Reach, our colleagues at Thames who are doing an excellent job actually. But then there was a time where you reached out and you said, I don't think that is fair. I have people.
We did think that.
Absolutely. And I remember, and I thought you were absolutely right. Absolutely right. So I remember reaching out to our associate director for Bromley, who's now retired, Helen, really wonderful lady. And she said, yeah, go ahead and we accept referrals. And so it was credit to you that now we say, how do we work with this? They don't need to have to be verified as rough sleeping, but as long as they are willing to be verified as rough sleeping, so we take that approach.
I often get asked this question about people with mental health issues and homelessness. They often say to me, this comes actually from local authority normally, well, why wasn't this picked up before? I said, because they're very good at masking things.
Yes.
If they're in a job, stable, but it becomes an issue when all of that goes and they're in crisis, and there it is. And they can't control it, they don't know how to, so then they try and mask it and they'll start drinking, taking drugs, doing whatever.
Yes.
So that's when it comes out. They're in that crisis because, as you say, that guy for 20 years, he could mask that for so long until it comes to a point where they can't mask anymore. And like Maz rightly points out, all you ever see on the TV is the negative side of that. The chain of causation, I'm talking, how did they get there?
Yes.
And that's what we look at, how did that person get there? Because if they need support in terms of addiction, if they need support for mental health, if they need support for other things that are going on in their life, that's what we need to look at too, so they stay in that property with the right support.
Indeed.
In terms for the podcast, just to let anyone listening know that Task and Target are meetings that services will have with the local authority, and we discuss every other week about people that are rough sleeping, who's doing what in terms of helping them and support them. Unfortunately, there has been change
At
Bromley, and there's been a change up of staff recently. So this has actually resulted in us not having a Task and Target meeting for a few months. And actually, I think from mine and Maz's point of view, especially yours, Maz,
And mine,
it's been a knock-on effect where
definitely.
actually as a multidisciplinary team, because that is what we are, we might be in our own little silos, but together as a team we are one strong unit that really help these people. And actually we can actually feel that we're struggling with a few cases, I think, because we've lost that connection, which we are people going to re-establish very imminently. But it leads to my point in the fact of quick access to care and services, especially around people experiencing homelessness. It can't just be you've got to have that level of understanding, and it's a bit more in depth, really, can't you? I mean, I can't personally imagine a newly qualified nurse stepping in here and being able to deal with my job, let alone with some of these mental health concerns, especially with the trauma background and things like that.
You need to be qualified, but you also need to have behind you years of experience. You can't just walk in and deal with someone in crisis. We've had people walk in here, and I do believe that a counselling service, along with your service there, has saved lives. Most definitely a counselling service. They've walked in here wanting to end their life. Then 2 hours later there's a different person that comes out of the room with a counsellor. I can't reiterate enough, if you're going to use this model, you need to have good counsellors, because where the mental health services are under so much pressure and there's waiting lists everywhere, this is what's important. Talking therapy is really important. Look, it's not the be all and end all, but it's a starting point. And when they feel they're being listened to, it's cathartic in some ways. This will come back and they need other support. But I have seen people walk in here thinking to myself, if we weren't here, they probably wouldn't be here tomorrow. So it is really important, this service, the counselling service, most definitely.
Absolutely, and I just want to say, what we have is that, again, when you look at stats and everything, statistics, what you find is that unfortunately, when somebody ends up taking their life, that's when the attention is focused on, well, this person died by suicide and so on. But the credit for how much lives you've saved from this intervention we all do together, is never there. No. We don't know how to quantify people, through that interventions, saying hello, buy somebody a cup of tea, having a chat with them, having a crisis and safety plan with them, and so on. You don't know what they're thinking of and what difference it makes to people's lives. But the unfortunate situation whereby somebody ends up taking their lives, that all the spotlight is on you as a service or as a clinician, and saying, what went wrong there. So, but again, these are things that we need to be bearing in mind, really, in terms of
And you're right to highlight the fact that we don't jump up and down about the lives that are saved. Neither does the NHS. No one does. It's all about what didn't you do.
Yes.
And actually, let's step away from negativity and let's look at it in a positive way. Look at what we do. That's what you should look at. Yes, there's always going to be, in any service, blimps, things that happen that we can't control. But the majority of the time, we're all sitting here trying to do a good job. Best practice, gold standard, that's what we aim for. Everyone does. But the highlight is always quite negative in the press when it comes to anyone with mental health issues, anyone that's rough sleeping. There's a negative narrative around it, and that really needs to stop.
I read a book, Professor Nicholas Barr, he writes about economics and so on. Economics, I think the book was Economics with the Welfare State. And what he actually talks about perfect information, this in relation to health insurance and so on. And I thought that was a brilliant way of putting it, in the sense that even as we sit here, we do not have perfect information about our own health and well-being, because I could be sitting here talking to you, but I don't know what's going on inside me until I start feeling the symptoms and so on, But that's equally true for people we work with. You could ask somebody, do you have any thought of ending your life? And they may say no to you, and genuinely they may say no to you. But they'll go out of the meeting with you and they hear some news, or something might have happened to them in terms of negative life experiences, bad news or whatever and become so overwhelming, right? They end up taking their lives. We don't have perfect information in terms of all we can work with is what is in front of us in terms of what our assessments, I think that needs to be taken into account in terms of we can only work with what's within our reach and what we're aware of, really. So
I mean, some of the cases that you see recently, Ricky Hatton, who has a history of mental health, so everyone keeps saying, who's recently died, he had a history of mental, that's all they say. Forget what he's done, the champion that he was, the first thing you read is he had a history of mental health. Why is that so important?
Yeah, exactly.
Than the person.
So that's a negative.
It's not the just look at the person, not what. It's the same with homeless people. A lot of the time, people just see them. They're a number on chain. We get to know the people.
Yeah.
And that's where we can give out important information back to those people that are making decisions. We know that person.
Yeah. I mean, you see it a lot. We've got to end here, but we do see it a lot, and you see it in general health as well. If you're on a ward working or something, they're like, oh, the lady with endometriosis or the one with the chest infection.
Yeah.
It's like, oh, the one that's rough sleeping with bipolar or schizophrenia or whatever, and you do label them rather than calling them by their name.
Yeah.
Or remembering a nice thing about them and things like that. So it is, as we always say, say hello, ask if you're all right. And me and Maz always take students from nursing backgrounds and things. So if any of our colleagues want some experience or anything, or come and see Bromley Homeless Charity.
We're happy to have housing officers in, come and have a look how it should be done.
Exactly. So we work together, and I think that's why all of our services are so good, and we just need to keep up the good work, really, guys.
Yeah, no, absolutely. I just want to say, and if I may, by actually paying tribute and give credit to Oxleas, because as I said earlier, our funding was for 2 years, and because there was no funding, Oxley actually, the third year as we are in now, Oxleas opted to fund the team moving forward. Hopefully we'll get funding thereafter from 2026, but also give credit to GP Alliance for
definitely.
providing the service that you are providing so well, and this is a model I'm hoping we will again copy across our 2 boroughs. And one of the things we've done successfully, advocated for in one of the local authorities, actually is have mobile dental services come and work with. So we're trying to meet the holistic needs, and I think. Final point from me, Kim, I think you're right, absolutely, again, I couldn't agree more. In terms of, I think the approach needs to be, we need to go out to people, not expect people to come to us, otherwise we're not going anywhere. That professional curiosity and understanding people's journey is key to making change to people's lives.
Thank you very much, Maz, for joining us today for this episode of The Corridor of Hope. It's been really enlightening. It's been a pleasure having you with us. Thank you to everyone for listening, and Kim and I will hopefully see you all next time. So take care. Thank you. Bye.